I'm Charles Wykoff, retina specialist from Houston, Texas. Absolute privilege to be here with two good friends and colleagues, Carmen Puliafito and Phil Rosenfeld, both giants in the field that need no introduction. Phil, let's jump right in. So you're a master of macular degeneration, both advanced forms, right? Dry and wet. And you've been focused now for probably a decade, maybe longer, on sort of the geographic atrophy angle. When few people clinically were talking about it, you had some landmark papers. You showed that atrophy was super important as a cause of vision loss, the Marina and Anchor data sets. And then more recently, your imaging has really sort of highlighted a choroidal role to geographic atrophy. Where are we in our understanding of geographic atrophy, and where are we headed?
Thank you for the question, Charlie. Carmen, it's great to see you. Yeah, geographic atrophy is currently the bane of our existence, particularly now that we can treat wet AMD with anti-VEGF therapy. And now we look in the eyes of these patients and they continue to lose vision. And those patients with dry macular degeneration are happy and they have good vision. And you know what the future holds. They're going to gradually lose their vision. And I originally got into age-related macular degeneration because I was trained as a molecular biologist, geneticist, and it was actually Joanna Seddon that got me fascinated as a resident because she was doing at a time where everyone was thinking about nutritional factors and sun exposure. She was doing an identical twin study. And in this study, she showed the concordance was amazing. Identical twins, if one has age-related macular degeneration, the other has it. So this got me interested in AMD from a genetics standpoint. And, Carmen, you probably remember Ephraim Friedman from the Mass Eye Institute. It was right around that time. And he believed in scleral rigidity. That's where the thinking was in the mid to late 90s. Scleral rigidity as being responsible for age-related macular degeneration. And along comes genetics. And suddenly people began to appreciate that genetics played an important role. And then 2005, with the Human Genome Project, the first genome-wide association study, and lo and behold, AMD, complement factor H, ARMS2, HTRA1, became the most tightly associated loci for AMD. And I think to this day, it's still the most highly associated loci after all these genome-wide association studies. So geographic atrophy is fascinating, because although AMD is tightly linked to the complement locus, there's almost no data to suggest that complement factor H alleles are involved in the growth rate, the formation of geographic atrophy. But yet, that's where we're focusing our research, because primarily that's where the FDA has given us the ability to study the growth of geographic atrophy as a clinical trial endpoint in phase 3 clinical trials for registration. So we have been focusing in treating AMD on geographic atrophy. And I got so excited about geographic atrophy and complement that I started the study called the COMPLETE study with Alexion using eculizumab systemically. And there's a lot of possibilities why that study didn't work. But as my biostatistician, Bill Foyer, said, we got an answer. It didn't work, okay? It definitely didn't work. And then along came Novartis with a C5 antibody similar to the one we delivered systemically. It didn't work when delivered intravitreally. Then along comes Genentech with factor D inhibition, intravitreal delivery. It didn't work. So we had 3 failures, one after the other. And there was a lot of skepticism out there about whether complement inhibition had any chance of working in age-related macular degeneration, geographic atrophy. And we can come up with reasons why all these previous studies failed. But my feeling was, the genetics points to complement. If we can't block complement in its entirety and demonstrate that geographic atrophy can't be slowed, then we can give up on complement, okay? It's hopeless. And then I started working with Apellis and C3 inhibition, and lo and behold, you block all of complement, and suddenly you can slow the rate of geographic atrophy. Very exciting, very, very exciting. And then Iveric comes out with Zimura. slows down the growth rate of geographic atrophy. And now if you look out in the field of clinical trials, we've got like 6 different companies developing complement inhibitory drugs that could potentially slow down the growth of geographic atrophy. It's really astounding.
Mm-hmm. And your work, particularly on imaging, focus on the choroid for me for a second. I think the choroid may be the most underappreciated part of the imaging that we do. How important is the choriocapillaris in this? Is that the genesis of GA?
Well, Charlie, that's a great question. We don't really know what the genesis of GA is, but we know what corresponds to the growth of GA. And what we've learned using swept source OCT and geography is that the loss of choriocapillaris throughout the entire macula correlates with the growth rate of GA. But we're still trying to figure out what determines the directionality of GA growth. We know the overall growth rate, but what we want to be able to do is say GA is going to grow from here to here, and that, oh, that drusen is going to turn into atrophy. We're not at that point yet, and we're still peeling the onion back, figuring out the different layers, the anatomic layers that are important. But one of the important things that you and I have learned, Charlie, is that when we look at, we're going to get back to neovascularization. When we look at new blood vessel formation, we have these type 1 lesions growing under the RPE, but they don't leak. They don't leak. And we've been torturing our data for the last couple of years. We've been trying to figure out what are the triggers that make these non-exudative lesions start leaking. So we looked at the change in size. No, it's not the change in size. We look at the choriocapillaris around the lesion. No, it's not the choriocapillaris. We look at the vascular complexity of the lesion. We skeletonize the vessels. We look at the vascular area. No, it's not the change in the vascular area. We look at the choroid. We look at the choroidal thickness, the choroidal vascularity index. No, it's not that. But we have an observation. The observation is that when you treat eyes with C3 inhibition that have this double layer sign, you get exudation. You get dose-dependent exudation. So maybe part of the trigger for this whole process is immunologic. And now we're starting to think that it has to do with macrophage switching in the back of the eye. So maybe complement works by taking prophagocytic macrophages, which are chewing away at the edges of GA, and turning them into pro-angiogenic macrophages transiently. That's part of the mechanism. So here we spend all this time and effort trying to study these lesions to figure out the triggers, because when you see these lesions in clinic, you want to be able to follow them closely and determine when they're going to develop exudation. But there may be an immunologic trigger that we just can't detect in clinic, and it's something that may be a side product of complement inhibition.
Fascinating. So is Apellis going to pan out in phase 3? What do you think?
Look, we wrote this commentary. Bill Foyer and I wrote this commentary last year, Why Clinical Trials Fail. Okay. And this was after the lampalizumab failure.
Yeah, I remember that.
The take-home message from the lampalizumab failure, if you look at their phase 2, in a traditional sense, it was a negative result. Okay, their p-value wasn't what you would typically accept as a clinically significant p-value. They stretched the definition. Then they looked at a subgroup analysis. Okay, right. And they found that complement factor I subgroup that worked well when given an inhibition with factor D drug. So then they moved out from a phase 2 to phase 3. And one of our central rules is, as famous biostatisticians say, perform retrospective subgroup analyses as hypothesis generating, but never believe the results, because there aren't any clinical trials in ophthalmology that have been proven to positive moving from phase 2 to phase 3 based on retrospective subgroup analyses, right? So that it never worked in the first place. And the other cardinal rule that we put out in this paper is, if you have a successful phase 2 study, don't change anything. That's another mistake a lot of people make. They think they're smarter than the average bear, and they're going to make it better, and they're going to start tweaking the clinical trial design. But don't fool yourself. There's a lot of variables with unintended consequences that can occur. If you have a trial design and it works in phase 2, move that clinical trial design to phase 3.
Yeah.
And I was determined that nothing would change going from the phase 2 to the phase 3. So it's a long-winded answer to your question, but yes, the phase 3 will work because the phase 2 was solid, statistically significant, no subgroup analyses, and the clinical trial design was identical moving into phase 3.
A last GA question for you. The phrase dead retina walking. I've always enjoyed that phrase that I believe you coined. If you didn't, please tell me who did. I always credit you as that phrase. Explain to us what that means in your perspective and why that's relevant to clinical trials in GA.
All right, so I'll take credit for dead retina walking, but that all comes from OCT. And one of the great contributions that Carmen made with his OCT and developing the Miami Macular Mapper in Miami is that we started using en face OCT long before it became popular with OCT angiography. People couldn't understand the importance of en face OCT imaging, and now they give themselves a dope slap. Of course, it's a really valuable way of imaging the back of the eye. And what we appreciated back in, 2008, 2009, was that when the RPE starts to die, it develops what we now call hypertransmission defects. The light now can penetrate through the RPE because it loses melanin. It's no longer reflected back. You get increased choroidal light penetration. We call them hypertransmission defects. And we started seeing that more and more in eyes with intermediate AMD, in eyes with exudative AMD being treated. And it became apparent that the retina was dying. The RPE was dying. And even though the person could see at that moment, it wasn't going to last. So we coined the term dead retina walking, because once you start seeing that, and once it gets to a certain size, it's the point of no return. The vision can't be recovered down the road. And now we're going to be using it as a clinical trial endpoint and studying treatment for intermediate age-related macular degeneration.
Super insightful. Really appreciate those comments.
So Phil, moving on to imaging. Is OCT angiography ready for prime time yet?
Carmen, in my practice, it is, because when you get OCT angiography, you also get structural OCT imaging. And that's an important point that people don't understand. Just because you get OCT angiographic scans doesn't mean you have got to put in the time and effort to look at the angiographic images. The images that you get just from structural OCT is as good as any structural OCT system. So I routinely get OCT angiography on the majority of my patients in clinic. That doesn't mean I sit there and take the time to analyze the results. People ask me, what are the killer apps for OCT angiography compared to structural OCT? And I have to be honest, the structural OCT by itself gives you almost everything you need. In fact, I don't usually get fluorescein angiography or indocyanine green angiography because structural OCT gives you most of the information that you need. The killer apps for OCT angiography, particularly swept source OCT angiography, is detection of these subclinical lesions, which occur in anywhere from 13 to 15% of patients with dry AMD, with drusen. And I think it's very important to confirm the diagnosis so you can follow those patients closely. Now, we play this game in clinic where we see the double layer sign on structural OCT and we guess whether a subclinical lesion is actually there. And most of the time we can determine if the subclinical lesion is there. So detection of subclinical neovascularization in AMD. And as our resident, now chief resident, Jonathan Russell, has done so superbly, is he's generated a series of papers published in Ophthalmology, Retina, and AJO now, showing that wide field swept source OCT is as good as wide field fluorescein angiography for proliferative diabetic retinopathy. So the two killer apps, there's one in AMD for detection of subclinical neovascularization, and in diabetes to look at the wide field capillary dropout, and pick up those early stage neovascular buds, as well as the more established neovascularization. And he showed, and now with the latest instrument, we have a 15 by 15 scan, which is truly amazing. So he found that by scanning on the macula and on the optic nerve, you can get 99+% of the neovascular lesions that you can detect using wide field fluorescein angiography. So do you need swept source OCT angiography? No, you can manage your patients beautifully. Are you going to get reimbursed for OCT angiography? Not in the United States. I don't know why, but we've hit a roadblock whenever we've gone for reimbursement for that code outside the United States. Yes, and that's why the instruments are selling like hotcakes outside the United States. But if you want to treat your patients well and do follow-up scanning so you can get longitudinal information, your patients will be grateful. And I think once you get used to imaging, particularly the diabetics, you get more information, more useful information. And I think it's time to start considering a whole new diabetic classification scheme based on wide field OCT angiography.
What about autofluorescence?
I use it all the time in baseline diagnoses. For routine AMD, I don't use it. I think it's useful for diagnosing other macular degenerations, rare conditions. I routinely do it, but in routine clinical practice, it's not particularly useful for the common diseases.
Charlie, do you have some questions?
Yeah, I got one for the patients, for the physicians that don't have OCTA, and they're looking for your double layer sign. And you said, articulate what you just said. You said with you and your fellows, you sort of have a game where you try to determine which double layer sign is going to harbor a type 1 membrane and which will not. What are those little subtle cues that the rest of us can look for that aren't doing OCTA on all these patients with these sort of confluent areas of drusen that might be harboring type 1 lesions?
Well, I think Robin Geimer's term that she published, and we went along with her because we were serving as the reading center for her OCTA images, is a Sire sign. And the Sire sign is a shallow, irregular retinal pigment epithelial elevation. And that's exactly what it is. You can call it a double layer sign. You can call it a flat, irregular retinal pigment epithelial detachment or elevation. And it's this low-lying pigment epithelial detachment. Occasionally it can look like a little druse, but it's usually a little bit larger than a druse, usually 300, 400 microns. She put 1,000 micron limit on it. I think that's too large. I think you can see them much smaller, and they have an irregular pattern. And the other key is look for the internal reflectivity. A druse usually, not always, but a drusen usually have a more homogeneous internal reflectivity, where the double layer sign has a more hyporeflective internal structure that if you have drusen on the same image, you can really distinguish between the two. There's a learning curve to it. And unfortunately, the best way to become an expert in the learning curve is to compare OCTA next to OCT structure, flow versus structure. And that's the other take-home message. If you're going to perform OCT angiography, you always want to look at your flow image en face next to your structure image. And you always want to look at your corresponding B scan with the flow next to your B scan with the structure. You can't forget the structure. Flow and structure go together. You got to look at both images to fully interpret what's going on.
Well, Phil, thanks so much for this wide-ranging discussion of imaging and how it all fits together in the future of macular degeneration.
Thank you, Carmen, and thanks for starting this whole OCT craziness. And Charlie, it's always a pleasure working with you in clinical trials and on papers. Thank you for taking the time to talk to me. It's greatly appreciated.
I look forward to much more.